3, 2, 1, action. We're live. Morning. How's everybody? How you doing?
I'm doing good.
Good. Well, I haven't had an opportunity to work with you all. Anyway, my name's Mike Wallace, and I'm captain here at CJC in EMS operations, and I do essentially this chapter 17. You'll see me again in ACLS. I'm regional faculty for Advanced Life Support, or for American Heart Association, but I've got a great passion when it comes to cardiology, and I hope that kind of comes through, and not only that, but kind of maybe hits a passion with you if you want to learn more and do more into this stuff. I've worked for CJC since '92, been in EMS since '88, and went to EMT school actually in high school, and I just love this profession. Had the opportunity to work for St. Luke's Health System in the emergency room, so I've got some exposure there. I've had opportunities to round with cardiology and be in the cath lab. I've got a lot of depth and breadth in this particular topic. So, chapter 17, as you know, is a pretty tough chapter. There's a lot of things in it. This is really going to set the foundation for ACLS. So as we move through this, it's important that you understand the anatomy and the physiology, and then work real hard in the EKG sections, interpreting, because then after we're done with this and you can recognize things, we're going to come back and talk a little bit about what's called therapeutic modalities. Why are the patients presenting the way they are, and how are we going to manage that as field personnel? So it's important, before we move into that everybody make sure that they understand rhythm strip interpretation and all that, okay? Because this is foundational, and it's going to build upon that. So, well, here we go. We're going to use this clicker. No.
Is your clicker not working?
No, it keeps jumping ahead. So this chapter is a big elephant. And how do you eat an elephant? Yeah, bite, one bite at a time. So that's what we're going to be focused on as we kind of move through here. So how we're going to do this is we're going to talk about the pump, which is going to go over into anatomy. Folks, that's nothing but reading your book, learning the anatomy, understanding it, understanding blood flow. We'll talk about that. We'll talk about blood flow as it applies to the container, being the arterial and the venous system. We'll go into depth into cardiac output and what that really means, and not just the definition, but what cardiac output should mean to you as field personnel, especially when you give medications that potentially can affect cardiac output. What I mean by that is nitroglycerin, morphine, dopamine in a way, affects blood pressure. And so how do all of those medications that we give, how do they affect that container and ultimately cardiac output? So that's going to be important. We'll talk about what happens in the cell to make the cells contract. What causes, what happens to make these cells contract? We're talking about these muscle cells to cause a muscular contraction. We'll talk about the chemicals, the sodium and the potassium pumps. What happens, with that? That's important for you to understand. What tells the myocardial cells to contract and to move blood through the heart? We'll talk about the heart's electrical system, the conduit, if you will, and those specialized set of conduction cells. And then we'll end the day actually looking at our first set of strips, which are sinus strips. We're talking about sinus tachycardia, sinus bradycardia, et cetera, et cetera. So that's how we're going to end it. You'll work after lunch. Towards about 3 o'clock, you'll be working into some small groups, break you up, and I'll give you more instructions for that. But it's going to be important that you really grasp the concepts of recognizing the sinus rhythms and applying the rules as we move forward, because then next week we start getting into atrial rhythms, then junctional rhythms, then ventricular rhythms, etc. So that's how we're gonna eat this thing one bite at a time. So what do you need to do to succeed, to be successful in this and to be able to move on? Well, you need to read the chapter, and you need to reread the chapter. First time isn't going to get it. Maybe the second time, maybe after My presentation today, I don't like the word lecture, because I'm not going to sit up here and lecture. So we're going to be very interactive and ask questions, okay? And reread the chapter. Do your workbook. You got a workbook? You all have your Dubin book, great book. I asked the group yesterday to read from the beginning to sinus rhythms in that book, because again, it's another way to get the information delivered in a completely different way, okay? And Dr. Dubin does a really good job of bringing it down to a real easy to understand level, okay? Listen and ask questions. Like I told the group yesterday, there's no such thing as a dumb question. Well, we all know that there are dumb questions, but you know, in the environment today, there are no such things as dumb questions. So if you have any questions, you don't understand a concept, please raise your hand, okay? And then, of course, do your small group assignments, all right? One of the reasons why I pair you up into the small groups is that there's always somebody that is stronger in this area than others, okay? And there are other ones that are weak, and then there's certain ones in between. By doing these small group assignments, the stronger people help bring up and reinforce the learning and applying the rules to the weaker people. And it has been shown that if you follow these rules, if you follow what it is that I want you to do in the small group assignments, you're going to do much better at rhythm interpretation. Okay, so I'll talk to you more about that as we move on. If you have to use the restroom, please get up and go. No big deal. You need to stand up in the back of the room. Feel free to stand up in the back of the room. I'm laid back like that. The only thing I ask is that you pay attention. Okay, don't really talk because I want you to get these things. I want you to get these concepts. Okay, all right. So I'll do what I can to help you succeed, and you have a role in this yourself. All right, let's start off with some thinking questions here, some true or false questions. All right. All right. With that said, true or false? Virtually every chest pain call is truly an emergency.
False.
False?
You want to treat it as an emergency.
Okay. So when we get down to maybe a discharge diagnosis or an admission diagnosis, would we say that every chest pain call is truly an emergency? Virtually every, virtually. Of course, any true or false question that says every, well, usually that leans towards the false, but why do you think it might be false?
Well, they could have chest pain from running, and it subsides as they calm down, or
Right. So there's lots of different etiologies for chest pain. And if you think about how many chest pains you run in your services, how many of those end up actually being an emergency? What we call maybe an acute myocardial infarction or an AMI. See, with chest pain, you're dealing with pain anywhere in your abdomen area on up, because we have what's called referred pain. So we have organ pain that actually refers and allows us to have symptoms in different places, such as pain, discomfort, pressure, things like that, okay? So you're going to run, out of your daily calls, you're going to run a lot of chest pain calls. Very few of them are going to be true emergencies. However, what this gentleman said, what's your first name?
Neil.
What Neil said is that we need to treat them as if they're an emergency. In other words, every patient we want to rule out that acute coronary syndrome or that AMI, right? And it doesn't matter if that's our first patient of the day or our 16th patient at the day or of the shift at 3 o'clock in the morning, okay? So, chest pain is a low frequency call type, true or false? False. You're going to get a lot of those, right? It's almost like a default. Well, can you describe, where I'm just hurt, I'm just achy. Does your chest hurt? Yeah, it kind of hurts a little. Bingo, chest pain, right? Okay. So, very high frequency call, very low frequency. Is it truly an emergency, a life-threatening type emergency? 12 leads are not required on all chest pains. True or false?
false.
Yeah, false, right? If they mention at all a chest pain component or an equivalent, such as chest pressure, I'm not able to describe what it is that I'm feeling. then they certainly need to get a 12 lead. And 12 leads are not just exclusive to chest pain, they're exclusive to syncope. We should be thinking about that. Respiratory distress, okay? And then basically anytime that you want to, all right? There's lots of different reasons why you would, but certainly on chest pain, if you have that chest pain equivalent, it does buy a 12 lead, okay? And we'll talk about why. True or false? The most common complaint of women with AMI is weakness. True or false? No chest pain, no shortness of breath, just unexplained weakness.
True.
False.
I got a true.
False.
I got a false. What say you, Mr. Spencer?
I go false.
Okay. It's actually true. The number one presenting complaint of women with acute myocardial infarction is unexplained weakness. No chest pain component. Remember what your textbook says of those people who have atypical presentations? Who are they?
Women.
Women. Who else?
Children.
Children. Who else? What about elderly? What about diabetics? Okay. As a matter of fact, when we go back and we look at what your textbook says, what does your textbook describe as an acute coronary syndrome or chest pain? What do they describe in there? As your typical presentation, what do they say?
Typical presentation, like chest pain.
Pressure.
All right.
Pressure, yeah.
Chest pain, chest pressure. Is there usually radiation to it?
Yeah.
Where does it go?
Left side,
Down the left arm. Where else does it
Jaw.
go?
into the jaw.
Into the jaw. And then what associated symptoms do we have with it? Signs and symptoms.
Shortness of air.
Okay, shortness of air. What else? What about nausea? All right. So my chest hurts here, it goes over to here and up into here. I'm diaphoretic and I'm puking and I'm having some shortness of breath. Did you know that's less than 50% of the patients that you're going to see who have life-threatening acute coronary syndrome event? You realize that? But yet it's in the textbook. Okay? The stuff that you see in your textbook are based off of an early study in the 1960s called the Framingham study. Okay, and it's still going on today. Okay, but back in the 1960s, they looked at patients with chest pain, and of those patients with chest pain, how many of them had a life-threatening or an AMI, or a significant life-threatening acute coronary syndrome. And so, based out of that, they came up with this symptomology that we see in our books. But think about it: who in the 1960s were enrolled in medical studies? In the early 60s?
Doctors.
Nope.
I mean, who was this test subject?
Who would they come out and recruit for medical studies in the 1960s, in the early
Men.
60s? Huh?
Men.
Men. Did you see women in medical studies?
Probably not.
Nope. Did you see African Americans? Did you see Chinese? Did you see Asian? Did you see any other racial? All you saw were healthy white men. Did you see diabetics? Did you see COPDers? No, we didn't. So the early results of the Framingham studies were isolated to fairly healthy white men. Is that what we see today? That's not what we see today. But yet when we look at it, that description, and we operate really well with that, don't we? And we walk in and we see this patient, they're grabbing their chest, right? And they go, my chest hurts, it goes over to here, it's up into here, and I'm puking in a bag, and I'm diaphoretic. Man, we're on our A game, aren't we? Oxygen, nitro, IV, 12 lead, all of these things. We do a good job, right? We do a pretty good job. But what about when we have unexplained weakness or syncope or unexplained shortness of breath? What about those? How do we operate with those? Those ones that are atypical, that fall out the window. See, those are the patients that present more often with atypical or non-typical chest pain, and they're having major issues. okay? So we really have to refine what it is that, in our thought process and how we're thinking, and really open up that index of suspicion to go, you know what? They are an acute coronary syndrome until I rule it out. Okay, and oftentimes that rule out's gonna be in the emergency room. Okay, it's gonna be in the cardiac cath lab. It's gonna be because of repeated cardiac enzymes, things like that. Okay? So just don't get reliant so much on what you're reading in the textbook, all right? You need to really be open to other things. So yes, that is true. The most common complaint is unexplained weakness. Oh, crud. Of all the 12 leads you will acquire on chest pain patients, 40% of them will likely be STEMI.
False.
Okay? So we have virtually every chest pain is truly an emergency. False. Chest pain is a high frequency call type, we know. 12 leads should be taken on every patient, okay? With an atypical or suspicion, whatever. And then of all the 12 leads that you take, of all of these call types, 40% of them would likely be STEMI. We say it's false?
Yes.
Okay. Any guess as to what it is on average?
Right, that's
5% or something.
Okay. Where do you work?
I don't work in the field yet.
Well, where do you work?
I work at the post office in Barton.
Okay, that's cool. All right. Where do you work?
Kansas City.
I was gonna say you're in Kansas City, right?
Kansas City.
Kansas City?
Oh,
Where are you working at?
so,
Self-employed? Cool. You're here. Sir?
Kansas City.
Kansas City, okay. Kansas City, how many chest pain calls do you run a day?
15.
A
lot.
Yeah, that's 15 probably in an hour, right? Okay? So if you were to take all of the numbers of 12 leads that you do, about 10% are gonna come up with a STEMI. About 10% of all of them. So we run on average, chest pain just itself, about 138, 140, just, now that's not syncope and all the other stuff, okay? And so we run about 13 to 14 actual STEMIs, okay, that actually have an ST segment elevation MI, so it's roughly about 10%. Which means what? You're gonna be seeing these patients and doing all of these 12 leads, and you're doing all of these 12 leads to discover what? To discover that, all right? Because this right here, when we discover this, is when we need to really ramp up what it is that we're doing. Early activation in the cath lab or in the emergency department, limiting our scene time, et cetera, okay? So, what's an acute coronary syndrome? I've referred to it a couple of times. What is it? Any ideas? Let's dissect the word here a little bit. What's acute?
Sudden.
Rapid onset.
Rapid onset, sudden, okay? What about coronary? Referring to what?
Your coronary vessels.
Okay, your coronary arteries in your heart, right? Okay, so we have a sudden event or issue in the coronary arteries, and there's a syndrome, which means what? Syndrome means,
Disease.
yeah, there's different causes, there's different potential issues, okay? So what an acute coronary syndrome is, I want you to think about it as an umbrella term, okay? So it's an umbrella term that covers many different things underneath it. And so with an acute coronary syndrome, you have the big one that we do lots of 12 leads to discover are STEMI. STEMI, ST segment elevation MI, is an acute coronary syndrome. All right? The next one would be NSTEMI, or what they call a non-ST segment elevation MI. In other words, we don't see the ST segment elevation on the EKG, but heart muscle is being destroyed, okay? And then the next one would be angina, stable angina. You're familiar with that, and you will be. We'll cover this in this chapter. And then the last one is unstable angina. Okay? So what we're talking about is we're talking about disease of the arteries that supply blood flow to the heart. All right? And we'll talk much more about that. So that leads me into STEMI. So what do we know about STEMI?
Meaning ST, positive ST elevation is 2 or more leads.
Okay, and what does that mean for us as EMS providers? I kind of alluded to it just a little bit ago.
That there is gonna be death of the heart if not treated.
It's affecting more than one.
Have you heard the term time is muscle? You heard that, right? Okay. We also know that what time is brain, right? Okay, brain cells. I want you to think about that muscle not as a muscle. I want you to think of time as muscle. I want you to think time as pump performance. Okay? I want you to think of that heart as a 4-chambered pump. Okay? And time, the longer that that heart is not getting the oxygen that it needs, the performance of that pump is going to become impaired. Okay? All right? And when we get into 12 leads and talking about acute myocardial infarction, you'll understand more, okay, with that. So time is pump performance. So what's our goal with that? So we have a patient who's got a STEMI, or we suspect a STEMI, and so from the EMS side of things, we do what? We do a STEMI alert, right? We call the hospital ahead. We should be doing that not at transport, okay? Not at transport. In other words, we've got the patient on the cot in the back of the ambulance, and now we're going down the road, and we go, oh, by the way, we have a code STEMI activation. That should be one of these things at the patient's bedside. We should be getting our 12 leads within the first 5 to 10 minutes of arrival, okay, at the patient's bedside. We do this 12 lead, we pull it out, and we go, click over on your radio and call whatever the closest cath lab is, and do your STEMI activation. Okay? That's how you're going to really speed up that process, that door to balloon, okay? Getting them through the emergency room into the cath lab. Ultimately, the earlier that we can activate, the quicker that we can get them into the cath lab. The quicker we can bypass the emergency room, because that should be our goal. Our goal is not to go in and go into an exam room and move them over to a bed. The goal should be on our cot, we wheel through, we pick up an ER nurse, we pick up a cath lab nurse, we meet the cardiologist, we hand him the EKG, and we continue on into the cath lab. That's what we want to do, okay? When we do that, we're providing the best care that can happen. But is that currently happening?
No.
Now, let's take a look at something. AMI and heart disease is the leading cause of death in Missouri and the United States. Well, we always knew it was the leading cause of death, but it's also the leading cause of death in Missouri and in Kansas and in Texas and Oklahoma and everywhere else, right? In 2010, Missouri's heart disease rate was 12.7% higher than the national rate. Missouri was 10th highest in mortality of all the 50 states. The prevalence of heart disease was higher than the national average, and we ranked 13th out of the 15th for heart disease prevalence in 2010. How's Missouri doing, right?
Great.
Yeah, the show me state, right? The show me state, okay? I did a presentation at EMS World, at the EMS World Conference, and it was on acute coronary syndromes, essentially, and so I put up the rankings of the fattest states, okay? And so it was really, I mean, Missouri was way up there at the fattest states and everything. But the only thing that I could do that was really cool is I showed that Georgia beat us in obesity. So I got to throw that up there. Here, of course, I showed all these pictures of barbecue and French fries and all the things that Kansas City's known for, you know. And then I got to throw up there that Georgia was fatter than what we were. And then afterwards, this lady came up and really gave me hell because I made fun of Georgia and obesity issues. It's like, it's not what I was trying to do. Let it tie in, but I'm sorry I offended you with that. I didn't mean to. All right, so we know we've got an issue, but let's take a look at some real hard facts that I think present challenges, not to us necessarily because we work in the urban, suburban area, and we've got a lot of access to quality, fast, cardiac care when it comes to cath labs. But what about our friends and colleagues that work out in these areas that don't have that access? Okay? So white that's pretty good places. That's where you want to have your issue, because the white, you have access pretty quickly to comprehensive cardiac care. But as you get into the darker colors, you don't, okay? And so those are the ones with the higher and the highest mortality rates, okay? So that creates a problems and challenges. So let's look at some other things. Even though we're really educating about the importance of doing STEMI activations and getting 12 leads and tying EMS into the system of care, because I remember when I first started teaching 12 leads, I had to come into groups of people that they would sit there and go, it's not going to change the way I treat my patient. I don't know why I'm doing it. It's not going to change the way I treat my patient. Well, luckily that paradigm shift has come and gone, and so people really realize now that we do have a critical role in treating these patients. However, in general, untimely reperfusion is still very, very common. Matter of fact, 30% never receive reperfusion. 30% that are eligible, that should be reperfused, end up not getting it. And we have to ask ourselves, why is that still an issue? Why is that still an issue? Less than 40% have a door to balloon within 90 minutes. Why? Is it an access to care? Are there barriers? Why? Especially today. When that coronary artery becomes blocked, okay? And you'll understand why here. I'm setting the foundation here, okay? When that coronary artery becomes blocked, every 30 minutes, that patient's 1-year mortality rate goes up 7%. 7% every 30 minutes. When do these people call us? Is it right when they start having chest pain? No, they've usually had it for 30 minutes, 45 minutes, a couple hours, all right? Many of them go to bed and never wake up, okay? So this is a huge issue. Well, the state of Missouri has done something through what's called the TCD legislation, time critical diagnosis legislation. You guys familiar with that? You should, because you are now bound to, by law, by regulations, to actually transport according to the TCD plan. Okay? Now, there hasn't been a lot of education, obviously, because very few of you have ever heard of the time critical diagnosis plan. But essentially what it has done is it's looked at this issue. It's looked at this problem in the state of Missouri, and it started with Dr. Bill German years and years and years ago, who died of an MI, by the way, the day before the legislation was passed, okay, for the TCD. But it looks at this and it says, you know what, we need to look and go, why are these patients not receiving reperfusion, and why are these patients not getting their arteries opened up within a timely manner, okay? And so what Dr. German's vision was is that he looked and he said, are there current systems that are working really well that I can model this after? And he just looked at the trauma system. See, when the trauma system was first designed, where we had level 1, 2, 3 designated trauma centers, they never expected it to have the impact that it actually did on trauma care. Okay? And it had a significant deal, because what they did is it went in and it looked at all the different possible barriers to reperfusion, and they eliminated those. They came up with a set of standards, etc. So state of Missouri, they did the same thing. They said, you know what, let's designate hospitals as level 1 through 4 STEMI and stroke centers. Okay? And then let's come up with transport guidelines for EMS to say, you know what, if you're having a stroke, here is your transport guidelines. If you're within X amount of distance, transport it to this one, okay? For us in the Kansas City metro area, it's not going to have an impact, because essentially, you know, we're going to have several level 2s and then only a few level 1s, and it's not going to matter which one of them you take the patient to, so it doesn't impact us necessarily, okay? People out here, it does impact, okay? So you're going to hear a lot more out there when it comes to, you know, TCD and specific education about that law, because it's now applies to you. Okay, it's been passed and all that. What they're doing now is they're designating the stroke centers right now. So they've done their site evaluations. They haven't released yet who the level 1 through 4 stroke centers are from Missouri, the Missouri TCD, and then they'll go back in and they'll start doing STEMI. And then once they release the STEMI and the stroke, that's when we'll do this whole statewide education, more really targeted to these rural areas, okay, because it's really gonna have an impact. Yeah.
I'm not familiar with the